According to our agenda, we now have a period of time for discussion from the floor, which could be comments or specific questions directed at our two presenters this morning.
Good morning, everyone. Somebody always has to start, so I don't mind doing that for everybody. I'm Ko Salish in Nuchalnath from the Vancouver Island area, and I work in the field of early childhood development, where the light of our communities starts, I hope. So, having said that, thank you to our two visitors from other countries. And I don't have questions, I just have a comment in how I've used cultural safety practice or have been developing it in our programs. We're early childhood development, we're infant development programs, primarily home visiting with parents, young parents, at-risk children, or children with developmental disabilities or delays. And we parent the way we were parented. And if our parents were raised in institutions, they weren't parented very well. So that's our whole goal in working with our Aboriginal children and families. So we've started to incorporate cultural safety. So I know it originated from a health background, but it works very well when we're working within our cultures and our communities. So I just wanted to say that. And on the other side of that, we're in the process of a lot of capacity building in the field of early childhood development. So at the same time, we're working with cultural safety. I'm striving hard to have mainstream folks, government folks, understand that the capacity we have within our community is we have cultural knowledge, we have community knowledge, and that's so important when we're working within our own communities. So sometimes that book knowledge they don't have that, but they have the other knowledge, which is very important, their culture and language. And I think that all fits, and I like the model of cultural safety, and I have learned more today, and I will certainly make sure we put that into practice because it does fit in other fields, not just the health profession. So Haichika.
Thank you. We had a bit of a chat about this during the break, and it's wonderful to see that people do see its application beyond health and indeed nursing and the helping professions. And what we were talking about during the break was as long as you keep to the key principles of cultural safety, then within any profession where you are providing a service, I believe it can apply. And obviously, early childcare is a wonderful service to have cultural safety embedded within the training or the provision of the services. And I think the stories need to be told, and hence why my book came about. And I was also sharing with Dianne that it would be my dream to see that folks in Canada or within the regions here would take up the challenge perhaps to provide their own body of knowledge in a written form and have the stories shared as well, because I think it's one thing to have anecdotal evidence and another one to have it in a published format. Yeah, thank you.
I'm a project coordinator for public health for interior health, and I have a question for Dianne. You described using a staircase analogy, cultural awareness, cultural sensitivity, and cultural safety. And I'm wondering if you see those as a progression, and do you need to have these precursors before you get to cultural safety? And if not, what basically are the elements that are needed to be in place to ensure that cultural safety can occur?
Thank you. Essentially, because the cultural safety program, as you like, is embedded within a 3-year degree, that's just the process they have used to help undergrad students fully understand the process. Having said that, we do also teach cultural safety to post-registration students, like graduates that are registered nurses already, and then they come back to Bridge to get a degree. And we still go through the steps, but the time frame is compressed. I don't believe that you can jump straight to the last step without knowing, how you get there. But of course, the people that are already working in the field would have life experience, etc., to draw on to do that. Basically, the undergrad students, it does take a while, partly because of their age and stage of development, and linking the theory of cultural safety to their practice over that time frame as well. And yes, but I think the going through those steps is still important, but you could just compress it for different groups.
And is that also true of institutions as well, in terms of their progression towards cultural safety?
It's a different ball game altogether. We're hoping to build the capacity of folks going through the programs to already have that knowledge, so that they can then relate that over to the institutions as well. But it's really embedded in the practice relationship with the patient. It's more where the focus is, and so the policies aren't always reflective of the practice. So there is a bit of development needed there. Yeah.
If I could just talk about the institution where I am, that we actually the university has Indigenous education as part of its foundation statement, a commitment to that, and as a result of that, by 2010, Indigenous content must be in every degree program across the university. We've got about 50% by 2008. We have achieved that. So we're in discussions, but a number of the staff in the David Uniapon College teach into different degree programs, and one of my colleagues, the Ngarrindjeri woman Sharon Gollan, whose background has been as a manager in Aboriginal services in the State Department of Family and Community Services, actually teaches a number of courses into social work and social policy, and she refuses to have any of her courses offered externally. You must do them internally, and she also sets a limit of 30 people per workshop, and they are really, taken through in a very. It's a very challenging course, but she has very high feedback from students by the end of the course. She's had the highest teaching scores in our college for her work. So, so we are aiming to bring that university. It will be unique in Australia in the sense that every degree must have some Indigenous content. Sometimes it's a whole course, and sometimes it may be part of a course. And where possible, obviously in the future we'll be having more Indigenous people teaching in there, and we don't have anyone in engineering and computing and information technology, which are the areas that still have to have content delivered. And I spoke yesterday about the challenges in relation to engaging with science, and I think I sort of did some further comments then. But yeah, our university, and on paper it looks very good, and compared to other places it is probably moving along, but we certainly, the struggle within your own institution is different internally than how people see it externally, but we have done that. It's the first university in Australia that has done that.
Sorry, just to add on, just while Jenny was saying that, in terms of hanging cultural safety onto a framework for practice, what the institutions that in New Zealand tend to have within their equal opportunity employment policies is a statement about the Treaty of Waitangi, and that tends to be where cultural safety links into culturally safe practices, linked to the workers' obligation, being able to meet their obligations under the Treaty of Waitangi. And so if cultural safety isn't used as such, it's reframed in sort of way, although that is a bit different because it's more to do with Māori people and meeting their health outcomes. But yes, I'll just reframe that.
I just had a question to add to what you were saying. When you say that each degree program must have Indigenous content or course, then that is mandatory for that student to take that in order to achieve their degree?
Yes.
It's not an elective?
No, it's not an elective. It's compulsory, and it needs to be accessible. So, yes. So in some places they've actually listed it as a compulsory elective. In other places they've actually have it as the core part of the program. So it's in that stage.
3 cheers to you.
Yes, to the people that came before me. That's right.
I'm not sure who I'm addressing this question to. In listening to the framework, I think it would be easy to impart knowledge. I think it would be more difficult but doable to impart skills. But I'm wondering if you're aware of any strategies or what is happening in terms of changing people's beliefs and value systems. I mean, how do you influence something that has been shaped by an environment that denies our existence?
I guess in New Zealand, as we said, the first step is the person knowing their own values and beliefs. So, as some of you may know, it's very hard to change attitudes and values, because if you use the iceberg analogy, if you like, the values and attitudes only surface when there's some sort of conflict, and so people tend not to declare their attitudes unless they have to, and so it's really trying to bring that to the surface instead of perhaps waiting for a situation where there is a conflict and then you have issues. So I think exploration around what are people's taken for grantedness and values and attitudes is really important as a starting point before they launch into, well, how do I work with those different populations out in the community? Because that is the risk. People, if they haven't done that reflection on their own biases and all the rest of it, that they just have an outward-looking perspective in their jobs and think I'm acultural, or I don't have any values and beliefs. I'm just the nurse or the social worker. I'm just the tool, as it were, to provide the service. And so it can be quite challenging because you are looking at their worldview, and because we don't teach our colonial history in the schools in New Zealand, we do end up with adult learners who have a certain view of the world, and so it can be seen as brainwashing because you are challenging, that view. And the New Zealand government are starting to teach our colonial history in the schools. It will take a while, but I think the change will come about over time, maybe another generation perhaps, where we're not faced with having to teach our history to adult students about things that have happened in the past, and then the attitudes hopefully won't be so ingrained about superiority over other cultures, etc. So I don't know if that answers your question. Yeah.
Thank you.
I also want to add to that the effect of Aboriginal people going into professions and graduating and then changing the policies in those places is really important. And in Australia, certainly I'd have to acknowledge the work done by Aboriginal doctors and their changes to the National Health and Medical Research Council and to ways of conducting research in the health area. They have made an enormous impact. It's just been just an amazing impact. So when you are in, and also to acknowledge, like the head of the National Health and Medical Research Council in Australia, before he was appointed, had written a book called The Cultivation of Whiteness, about medicine in Australia, and so there you had, just ideas are changing, and also I mentioned yesterday that the University of Melbourne again, and whether it's because Ian Anderson has a lot of influence there as well, but I think there's a desire by some universities that all students will take a first degree that will educate them about history and other things to become good citizens before they go into a vocational area. And, that I know in medicine in Australia, in many universities, you have to have a prior degree. So many people are coming in, then it's changing the culture of that practice. Just coming in with an arts degree, often many people are engaged in discussions around history and understand, like, for example, in Australia, what the history wars were about, so.
I'm from the Jewish people, not from an Aboriginal tribe, or nation, but we're having a great difficulty as Jews to keep our youth and even the adults aware of their past, aware of the richness and importance of what makes us who we are as well. It seems to me that if cultural sensitivity is evaluated in the person who receives the health care as well as directs their health care, it's imperative to support that type of education of understanding their past to then be able to direct and maintain and demand, which as a nurse I appreciate when a patient demands what they need. So it's clear. What have you been doing in your two respective countries to support, educate, and maintain the knowledge of your people in your past and history? Because this seems key.
Are you talking about Indigenous knowledge of
Yes.
Māori people?
Yeah, of the people themselves, of their own culture.
I don't know if you know, but Māori language was verbal before the missionaries came, so they didn't have a written language. So a lot of the language, the stories that they were recited, and knowledge was thought to be very precious, and so only certain people were instilled with what they called whakapapa, or genealogy of where people came from. And with colonisation and the missionaries introducing the written word, the stories changed and got lost and all the rest of it. And so some of that knowledge has been lost, unfortunately. And it's really a matter of trying to have people connect with their past and I guess not have to apologise for their past and where they come from, and it takes a lot of sensitivity around engaging with people around that. And as I said before, we have cultural cringe in New Zealand where Māori people occupy the moral high ground because of our colonial past, and so the non-Māori or Pākehā students don't really know how to deal with that when they start hearing the pain of Māori stories about grandmothers and grandfathers being caned at school for speaking their language, and all those sorts of stories. And so it's really what some schools of nursing do, and social workers, they have what's called a parallel process in the classroom where the Māori students break off and tell these stories amongst their own, and the Pākehā students do the same, and that seems to work in some colleges because it's almost like a marriage, I suppose. Sometimes you need the partners to break off and do their thing and then come back, and so that seemed to be the way to model the partnership model with the Treaty of Waitangi, is to first have the knowledge shared within their own cultural group so that they feel safe to tell the stories, and then come back and share it with the other partner. I don't know whether I've answered your question, but it's really celebrating all the differences, isn't it? And then being able to engage beyond that.
perhaps I was unclear. What I was trying to get at was the people themselves who access healthcare. What strategies you use in the communities to support and educate and encourage the knowledge of their own past in the community, so that then they can go and direct and demand the cultural safety that they deserve.
Our legislation does support that, and we do have quite a few Māori health providers, so Māori people would feel safer to go there and express themselves, if you like, whereas they're still less likely to do so in a mainstream setting, so that there are pockets of those providers, but it's not perfect. Yeah, you don't always have people voicing themselves, and what happens a lot in Māori culture is the nanny or the grandmother may not, like you said, it's good when people demand, a service, but with a lot of Māori people they won't say that, and so they will tell their relative, or they'll just not turn up for a service, and so that's another way that they express the service is culturally unsafe. So they may not verbalise it in the Western sense of I'm not happy. They will do it in other ways by not turning up, or perhaps telling their relatives, and then you kind of hear, down the line what went wrong. Yeah.
In Australia, they have probably over 100 Aboriginal community-controlled health services, which were actually the very first community health services in Australia. They actually were set up the year before the Leichhardt Women's Community Health Service, which had been considered the first community health service. They were actually, Redfern in Sydney was set up the year before in 1971. Or 1972, one of those. So that network of Aboriginal community-controlled health services has actually enabled negotiations and partnerships across the board in Australia in relation to different health instrumentalities and between the tertiary, secondary levels of healthcare. It started the development of really good programs. In fact, they led the charge in relation to using the words social and emotional well-being instead of mental health. Unfortunately, sometimes the mainstream health service doesn't acknowledge the way that people go about it, but certainly I remember one of the professors in palliative care in Adelaide, Professor Ian Maddox, wrote a paper called Aboriginal Health Research Ethics, Ethics for Aboriginal People or Ethics for All. And it was really, they basically set the pace. They set the pace. When you've actually looked, as Irene Watson says, when you've looked down the barrel of genocide, you can set the pace. You know what your responsibilities are. And so they have led an enormous amount of work in Australia, and the health system refers to those services in negotiations at all times. In relation to health workers, for example, who've never gone through to get a university degree, our college is also offering next year access for those people who've been working in the system for a long time but have very little protection when they're working in the mainstream system, to actually an opportunity to get a degree. So we're actually offering a graduate certificate which myself and Irene Watson, for example, she'll be teaching a course called Law and Land and Policy and Governance. So we've got the senior Indigenous scholars who'll be teaching that course to our, we want a majority of our community in those graduate certificates. And that's a pathway, if people find they really like study and they really like research, it's a pathway through to a master's and then on to a doctorate. But we really would love to see those ideas that are currently out there in the community that are held by people with so much experience turned into research work that can be then shared. That's also our hope, as well as providing a qualification that also protects them in their workplace, as well as opening the doors to their grandchildren to say we have created a safe place here. So,
with that, I would like to thank Jennifer and Dianne for their presentations this morning and all the participants who asked questions. There's going to be another opportunity at the end of the day for discussion.